Okay, it's 9 o'clock and we're going to get started. If everybody can take their seats, please. We do have a phone that was just found. So if this is your phone, let us know. Okay, hi everybody. Good morning and welcome to Georgetown University's McCourt School of Public Policy. My name is Kevin Lucia. I'm a research professor and co-director at the Center on Health Insurance Reforms. For all of you who are not familiar with our center, we are a team of health policy researchers dedicated to studying and advancing evidence-based solutions at the federal and state level to improve the U.S. healthcare system so that everyone can get coverage and care that they need at a price that they can afford. We publish numerous research studies and reports and also provide technical assistance to federal and state officials and other healthcare stakeholders. We're delighted to have you at this event. We really appreciate you all being here. We thank you for that. As we're starting to explore the larger question of why healthcare costs are rising, with a focus on big medicine and the implications of vertical integration for patients, providers, and employers. As many of you know in this room, consumers are now receiving their care from healthcare systems in which the health plans, the hospitals, the physician practices, the PBMs, the pharmacies are increasingly owned by the same entity. This trend has been happening for many years now, and at the same time, consumers have been facing skyrocketing healthcare costs, double-digit premium increases, growing barriers to care, and rising consumer medical debt. Today, we're going to hear from an incredible panel of experts that will examine the implications of vertical integration on patients, providers, and employers, and explore policy solutions to these what some think are problematic financial relationships that often put profit-seeking over patient care. I particularly want to thank the sponsor of today's events, Arnold Ventures, for their commitment to improving affordability and quality of health insurance coverage. There are few issues that are more complicated and challenging, and they as an organization are taking it head on. I also want to note a couple of quick logistics. First, the event is being recorded, and we'll be posting the recording on our website, and we'll email it to everybody in the room and anybody else who signed up. Second, there will be an opportunity for you to ask questions of our panel, and when the time comes, just raise your hand and someone will bring over a microphone and take your question. That'll be towards the end. So as I said, today we have an incredible set of panelists, but before I have them meet all of you, we're fortunate to have video remarks from Senator Warren. As you know, she has been a longtime leading voice in federal policy regarding healthcare consolidation and consumer protections. She's reached across the aisle with her Republican colleagues to introduce the Break Up Big Medicine Act, which targets structural vertical integration directly. So let's hear from Senator Warren as she shares her perspective on the role of vertical consolidation on healthcare.
Hello. So I really appreciate the chance to join you virtually today to talk about how we can make our healthcare system more affordable. So let me start with one big point. The biggest healthcare companies in the world should not be able to own your pharmacy, your doctor, your insurance company, and your pharmacy benefit manager. That is a recipe for disaster. And it's one of the main reasons that healthcare has fallen so far out of reach for so many American families. Because for decades, corporate giants have gobbled up every part of the healthcare supply chain. And that allows them to jack up prices and to steer money to the companies they own. Look, this trick lets them avoid laws that are intended to rein in corporate profiteering, and it lets them pad their own profits. And it's not just patients and taxpayers who suffer. Independent doctors and pharmacists aren't able to compete. In fact, since 2019, nearly 4,000 independent pharmacies have just shut down, and almost 80% of physicians today work for a corporate giant. Look, it is time to end the stranglehold that these corporate giants have on our healthcare system. And that's why Senator Josh Hawley and I have introduced the Break Up Big Medicine Act. Our bill would break up these companies once and for all and lower healthcare costs for American families. No more CVS owning health insurance and pharmacies and PBMs. Look, it is a bold proposal, but frankly, it's not a new idea. We have done this before. We did it with railroads. We did it with banks. Some of you have heard of Glass-Steagall. We did it with telecommunications carriers. When it looked like the company controlling the railroad tracks was also buying up the business on those tracks, our government stepped in and said no. After commercial banks expanded into risky investment banking activities, which helped cause the Great Depression, we broke them up too. And let me just say that when Congress repealed that structural separation, that's the Glass-Steagall Act, in 1999, the financial system imploded just a few years later in 2008. Structural separation not only helps consumers, it actually helps make our economy more stable, because the same company shouldn't be able to be both a player on the field and the referee. And when it comes to healthcare, we need to fight corporate power and to tackle this vertical integration so that we can lower costs. That means the company that pays for healthcare services shouldn't also own the doctors or the pharmacists that are providing those services. Together, we really can unrig healthcare system once and for all. So thank you again for having me here today. You know, we could make some real changes.
Okay. Thanks for those remarks. Next, I'd like to introduce you to Jonathan Kanter, former Assistant Attorney General for the Antitrust Division of the U.S. Department of Justice, where he was the administration's most senior antitrust enforcement officer from 2021 to 2024. As Assistant Attorney General, he led landmark enforcement efforts across major sectors, including technology, healthcare, housing, media, labor, and defense. He is also the co-author of the article, The Rise of Healthcare Platforms, published just last year in JAMA. There's a link to this article in your brochure. It's a great read. I highly recommend it. Today, Jonathan is going to discuss the rise of these vertically integrated platforms, their impact on healthcare costs and delivery, and the role of the federal government going forward. Jonathan, thank you so much for joining us today.
Thank you for having me, and it's great to be here for this absolutely important conversation. If it looks like a duck and it quacks like a duck, it's not a hippo. The U.S. healthcare industry in 2026 is not the U.S. healthcare industry from 1986. So let's stop treating it like it's 1986. Which was a great year. I was 13 years old, Mets fan, won the World Series. It was awesome. But at the same time, you knew your doctor, you knew your pharmacist, you went to the doctor when you got sick. If you got really sick, maybe you went to the hospital. People weren't stressing out over their premiums in order to get health insurance. Doctors, when they wanted to treat their patients, didn't have to call some faceless bureaucrat in a different state who's never seen the patient in order to get pre-authorization. PBMs were a glimmer, let alone the behemoths they are today, controlling how much we pay and what drugs we're allowed to take, even when our physicians want us to do something different. The world today is different. Let's stop treating it like it's 1986 or even 1996. And so to begin accurately and adequately addressing the healthcare system and the challenges we confront today, we need to start defining the problem in a more realistic, more present way. This is something I playfully like to think of as mapping the healthcare genome, healthcare industry genome. We need to change how we think about healthcare. Let me elaborate. Think about that world that I mentioned in 1986 or 1996. Doctors were small business owners, pillars of their communities, let alone not employees. Hospitals were considered local infrastructure. Insurance companies were in the business of insurance. Go figure. Pharmacies were on the local corner. Since then, we've seen this radical transformation. Doctors and pharmacists are employees. They're not small business owners anymore. Insurance companies, as Senator Warren eloquently described, they're not just insurance companies. They're PBMs, they're technology companies. They own the providers. They own everything in between. Hospitals aren't local infrastructure, they're systems. Imagine that. A hospital that's supposed to treat a patient is a friggin' system. The insurance company and their bureaucrats dictate the path of healthcare, not the physician. The doctor and the patient might be inches apart, but they might as well be thousands of miles apart, because the decision has to travel all the way to that bureaucrat who's never seen, let alone know the patient who's making a decision. Regulations that are designed to address these problems, things like the medical loss ratio, that are supposed to make sure that healthcare costs are being devoted to healthcare, have become mechanisms to entrench market power. Why? Because companies are integrated now. An insurance company can bill itself by owning the provider or the PBM, and that could essentially be offset using the medical loss ratio. So now, in order to compete, you can't just be a physician, you can't just be a pharmacist, you can't just be even a PBM or even an insurance company. You have to be all of the above in order to adequately compete. And then you have to cross-subsidize using regulatory evasion tactics like the medical loss ratio. Today's healthcare is nothing like a hippo. It's a duck. So let's start talking about it as what it is, not what it was. But our policies have not adapted. We have not updated or closed the loopholes in the MLR that give these platforms the ability to cross-subsidize. We use things still like prior authorization to disempower the way physicians treat patients. And we have inexplicably, over the course of the last 25 years, allowed this industry to consolidate. The largest health insurance company in the country is also the largest owner of healthcare providers in the country. Let that sink in for a moment. Imagine that world from 1986. Imagine what people then would have thought the largest healthcare insurance company in the country was the largest healthcare provider. And nowhere is this lack of adequacy and lack of realism present in my area, one that I know, antitrust. In antitrust, for example, we still rely on these antiquated tools of market definition to determine and scope problems. We might as well be using leeches to extract blood to treat disease. And instead of saying what is obvious, which is the companies have too much power, the companies are exercising that power, and that the integrated nature of these companies has created a behemoth that makes it impossible to compete, we use these antiquated tools of market definition to try to suggest that a duck is a hippo. And what happens as a result of that? We end up thinking about healthcare policy as if it were 1986. We end up thinking about healthcare policy as if hospitals are local when they're systems, as if insurance companies are just insurance companies, as if PBMs are just mechanisms to lower the cost of drugs when we all know they're raising the cost of drugs. And instead, lawyers, people in my profession, are gerrymandering these markets to fit these old models of how competition maybe used to function. But if the facts and the models don't line up, the problem is not with the facts. We today often think of this, and often in the framing of today's conversation is about vertical integration. But I want to challenge you to think a little bit more broadly than even that. Vertical integration comes from a world where you used to have a factory and a manufacturer and then a distributor and a retailer. And it really was kind of vertical. It was two-dimensional. But using terms like vertical and horizontal in 2026, it's like watching 4K video through a black and white TV. You might see some of the images, but you're going to miss all the nuance. The fact of the matter is, today's healthcare ecosystem resembles more of a big tech healthcare platform than it does a vertically integrated manufacturer, distributor, wholesaler, and retailer. These are multi-sided markets. Good luck trying to compete in any one part of the healthcare system without having to plug in to one of these massive vertically integrated multi-side conglomerates. They cross-subsidize, they self-deal, they have conflicts of interest. All of these are market realities that are present today and getting worse, not getting better. When the facts and the models don't align, remember, the problem is not with the facts, it's with the model. And so here's where I feel like we need to go. We need to start calling the duck a duck, not a hippo. We need to update our models to embrace the obvious, which is that there are a small number of massive conglomerate healthcare ecosystems, whether they're the big hospital systems or the big insurance vertically integrated or integrated, platform integrated, vertically integrated, whatever you want to call it, insurance providers, healthcare companies that also happen to own the PBMs, that also happen to own the providers, that also happen to own the technology and everything in between. It's time for us to start updating how we talk about these issues, how we diagnose these issues. Because if we're going to fix it, which is what we need to do, we need to start accurately assessing what it is. And instead of trying to fit, bless you, facts into old models, let's start updating our models to fit those facts. So we need to move with urgency. We need to move with a new terminology. And the good news is there's great work that's being done here. Just the other day, a great paper came out from Erin, Hayden, and a bunch of their colleagues at Brown about the problem and how to fix it. We need to move with deliberate speed. We need to move with urgency. Today's conversation is going to help tee that up. And then we need to make sure our policy recognizes those realities. Because you know what? People recognize those realities. Doesn't take a lot of work to explain to a doctor why the healthcare system is broken. It doesn't take a lot of work to explain to a patient that the healthcare system is broken. They understand that there are a small number of companies that have too much darn power and that the decision-making needs to go back to the patient, back to the treating physician, and we need to shrink the power and we need to shrink the cost of everything else that sits in the middle. So let's go fix it, and I look forward to hearing today's conversation.
Thank you so much, Jonathan. I'm now delighted to introduce today's superstar panel, moderated by Bob Herman, who is the Business of Health reporter for Stat News. I'm guessing most of you are familiar with Bob's work. He covers some of the most challenging issues in the healthcare space, reporting on health insurance, Medicare, Medicaid, hospitals, doctors, and other corners of the industry, with a goal of explaining and shining light on the money flow through the system. Bob's an incredible journalist, and we're so pleased to have him guide our conversation today. I'd also like to introduce you to Erin Fuse-Brown, who's a professor of health services, policy, and practice at Brown University School of Public Health, the director of the Health Law and Policy Lab, and faculty member of the Center for Advancing Health Policy Through Research. She specializes in health law and policy, and her research focuses on healthcare finance, consolidation, and corporation. And I too want to pitch your article. I read it last night. It's great. There's a link in the brochure. It's really a great article, and I think it sums up everything that we should know about vertical integration, its policy implications, and potential solutions. Next, I'd like to introduce Dr. Debra Patt. She's a practicing oncologist and breast cancer specialist in Austin, Texas, and an executive vice president of Texas Oncology with responsibilities in healthcare policy and strategic initiatives. Dr. Patt also serves as the current president of the Community Oncology Alliance and on the board of directors for the American Society of Clinical Oncology. Finally, she's a professor at Dell Medical School at the University of Texas at Austin. Thank you for joining us, Dr. Patt. Misha Sharp is the Assistant Director of Policy for 32BJ Health Fund, a self-insured Taft-Hartley fund providing health benefits for over 200,000 SEIU 32BJ members and their families in 11 states and Washington, D.C. Over the past 5 years, Misha and her team have focused on tackling healthcare costs with a particular focus on high and rising commercial hospital prices through public advocacy, coalition building, and policy engagement at the local, state, and federal level. Thank you for joining us today. Their full bios are in your brochure, so just those short introductions, but we really couldn't ask for a better panel. We have in front of us some of the leading experts on vertical integration and consolidation in the country here. So please join me in welcoming and learning from these great panelists. We've made sure to build in plenty of time for your questions, so please also get ready for those, and someone will be around at the end to take questions. Thank you. I'll hand it over to you, Bob.
Good morning, everybody. Can you guys hear me? Okay, there we go. Good morning. It is very heartening to see so many people interested in vertical integration. I think maybe we're unhinged, but this is very nice to see. It's great to be with you guys. Just to start, vertical consolidation has even impacted my own writing. It's very difficult now to just write about a large company like United Health, for example. I can't just say a health insurance company. It's not really accurate anymore. But it's also kind of weird to say a health insurance and services conglomerate. It just doesn't roll off the tongue. So there are communication issues here too. And so before we start, I just want to ask, I think we just need to define, and the remarks beforehand did a good job of like laying things out, but I do want to just make sure that we get into the different vertical consolidations that there are. And Erin, it'd be great if you can talk about those, because the vertical consolidation that we have been talking a lot about today is a health insurance company that also owns pharmacies and doctors and everything else. But there's also the hospital physician. That's like the OG vertical consolidation, right? Where, you know, they're controlling the referral pattern. So if you can just briefly walk us through the different types.
Yeah, I think, thank you. The remarks before really did lay out that Jonathan laid out the problem, this multi-sided, it's not even truly vertical, but we'll use vertical because that's like the language that we have to describe it. But really, I think that the idea that there are these platforms that operate in multiple parts of the healthcare market is the best way to think about it. And then to think about these actual concrete examples, the United Healthcare, the CVS, Aetna's, but also the large health systems, and the OG of vertical consolidation in healthcare has been these health systems that buy up physician practices and other outpatient clinics. So that's all, to me, part of the same problem, which is the idea, or the same phenomenon, which is the idea that there's a scale that involves different inputs in the healthcare delivery system that comes with acquiring different points of contact. So if you're a patient and your pharmacy, your PBM, your insurer, your hospital, your physician or all the data, the revenue cycle management, all the stuff that happens in the background, if that's all connected in some way through corporate affiliation or outright ownership, to me, that's what we're talking about today. And I think that there are lots of different policies that we'll get into that have both encouraged and frankly been permissive of this type of integration. A generation ago, we were talking about it as fragmentation, that like the fragmentation of the healthcare system was a problem. And it was the thing that was getting in the way of, of care coordination and of like higher value and better quality care. And so we've sort of abandoned this sort of idea of a fragmented but local and potentially more competitive healthcare system to one where large conglomerates own multiple points in the healthcare delivery system. So I think that's we're talking about all of that, both the health system and physician integration, but also this larger phenomenon of think of these large healthcare companies that own multiple nodes in the healthcare system.
That's great. And yeah, Erin and your colleagues did just put out an article. It was really quite good. I was reading on the tarmac last night, so congrats. Yeah. Misha, I want to ask you on the hospital physician side. I feel like that is probably, as a large purchaser of healthcare, this is probably where you see it most, is negotiating against a large hospital system, and they also own physician groups that oftentimes never get reported because they're too small. They just happen. They're just all of a sudden owned by somebody else. So Misha, how does this work in real life for you? How do you see this vertical consolidation on the hospital system side affect you and your employees?
Yeah, it's a great question. And it can be difficult to suss out by just using claims data to look at ownership. But we're lucky that we have a really engaged membership. So one example is we have a member in Park Slope. It's a neighborhood in Brooklyn. They were going to the same doctor for years for allergy shots that cost about $100. The hospital bought the practice. The second that hospital logo went up on the door, those allergy shots started getting billed at $7,000. So that's one example, but this pattern is playing out with routine services over and over again. So maybe 5-10 years ago, 30% of CT scans were in a doctor's office. Now 40% of CT scans are in a doctor's office. This is important because the prices for that CT scan are going to jump 4, 5, 6 times when they move over to that hospital outpatient department, whether or not the physical practice actually changed or they got just acquired by a hospital and became a hospital outpatient department. So this has been the focus for us as a provider in terms of paying attention to those shifts in care and the price differences. But we've also taken this on at the state legislature with a bill called the Fair Pricing Act to try and establish fair prices or site neutral payments in New York State for the commercial market.
Yeah, and site neutral has been a big policy suggestion for years, especially on the Medicare level. But you're saying at least at the state level, they want to enforce it in the commercial market, right?
Yep, that's what we're going for, is on the commercial market, because you see those price differences on the Medicare side, but you see the same or more on the commercial side as well.
And would that apply to you though? Because obviously I'm guessing you're self-insured and you're governed by ERISA, not state law, right? So how all of a sudden you got to get Congress involved?
For Erin, who's an amazing ERISA expert and who helped draft the policy.
Erin, can you talk about that a little bit? Because we're getting into ERISA versus fully insured, and yeah.
So the question of whether or not states couldn't do this really does boil down to this, like whether or not the federal law, the ERISA law that governs employer-based plans, union plans, can be applied to, can states just sort of like even regulate these self-funded plans? And the answer is not directly, but they can regulate the providers, right? And so the New York's Fair Pricing Act is structured as provider rate regulation, saying providers may not charge the site differential payment. They may not tack on facility fees for the defined scope of outpatient services. And it's basically a provider regulation, which states are free to do. And then there is some sort of like reconciliation that happens on the plan side, on the issuer and the carrier side, but because it's framed as provider rate regulation, it can get around, we believe it can get around the ERISA problem.
Okay. Debra, I want to ask you, what are some of the most obvious ways that vertical consolidation is affecting you? You're at Texas Oncology, you're involved with the Community Oncology Alliance. Is it on the insurance PBM type side, or is it hospitals kind of encroaching on the independent physician side? How are you seeing it?
It's a great question. I would say both, and they're related. So on the PBM insurance vertical integration side, we live in a wonderful time of cancer care where we have amazing cancer therapies. About 40% of them are oral therapies, pills, oral oncolytics. About half the time, those are steered to PBMs and their vertically integrated specialty pharmacies. When that happens, we frequently have to go through processes like prior authorization, fail first step therapy, which is very different in cancer than it is in, say, reflux. And then the steerage by themselves, because when I give a cancer therapy, which is again 40% of the time is oral, I have to give that therapy and make a lot of modifications because these are toxic therapies, frequently requiring dose reductions, therapy holds to avoid toxicity in patients. Because 40% of the time or 50% of the time that's filled by an outside PBM and their vertically integrated specialty pharmacy, they're sending my patients the full dose of the medication that may be $14,000 a month after I've written for a dose reduction. And so it introduces waste and toxicity. And cancer patients that don't manage their toxicity don't benefit from a therapy quite as long, and they don't survive their disease as long. So it's a challenge from a care delivery standpoint, but we also see it from a hospital consolidation standpoint. So as was mentioned, private independent practices are much less expensive in the outpatient setting than the hospital outpatient side of service, about half on average in a hospital side of service in comparison to a physician practice. Texas Oncology is an independent physician-owned private practice. And in many of our markets in Tyler and Longview, there's an evolving story of consolidation within the hospital system. In Beaumont Baptist, outside in the Gulf Coast, there's a story of gobbling up private cancer practices, and the cost goes up. I think one that's gotten a lot of public attention is the Alliance Hospital System in the Philadelphia market, where ARIA migrated with the Jefferson system back in 2015. And in addition to increasing prices when patients were seen at the hospital outpatient department, they restricted privileges to exclude the Alliance Cancer Center doctor, the private physicians from the market, and they even threatened penalty to doctors within their system if they made external referrals to those doctors. So they filed a lawsuit, an antitrust lawsuit, and lost. Alliance did in 2023 about that system. But those two different problems are actually really related, and they're related because of a policy that connects them that's had a great impact on cancer care and access in the country. And that's the 340B policy, where qualifying entities, but mostly at this moment, disproportionate share hospitals are able to purchase drugs at a discount, maybe a 50% discount, but it's variable. So this is a large way in which there's a financial incentive for disproportionate share hospitals or qualifying entities to consolidate or gobble up local cancer practices. And this has been our observation because there's a tremendous arbitrage opportunity to purchase drugs at a low amount and sell them at a higher amount, because while they're purchasing at a 50% discount, they're charging a fully insured patient, their employer, full ticket, right? So they're paying the full amount. And so this has been a program that's grown, and I think it's over $150 billion in value. So while you would say it may be $60 billion in drug purchasing, the employer-funded insurance plan is paying the full cost of those medicines, which is about $160 billion in, maybe it was 148 in 2024. So, but it continues to rise. And I think that the largest growth, why they're connected, is in 2010, after PPACA, there was an expansion of the contract pharmacy relationship in the 340B program, where hospitals could have an innumerable amount of contract pharmacy relationships because of the change in HRSA regulation. And when they do that, that means when Debra Patt sees a patient at Texas Oncology in Austin, Texas, because most of my patients have touched the hospital system at some point in time, and I have privileges at my local hospital system, which all of them are 340B. When that script is steered to PBS, to CVS, frequently it is post hoc adjudicated as 340B. So their employer is paying full ticket, and the hospital and CVS are splitting a margin-based profit. And so I will say that while that program provides a lot of services for vulnerable patient populations today in many centers, also, it was never the intent of the program to have CVS take 15% margins on these very expensive drugs and have employers charge full ticket or pay full ticket. So what we see with that natural consequence of the policy is that it continues to drive vertical integration, hospital consolidation in the ecosystem, and that continues to grow independent of the population changing. But what I know as an oncologist is that the population is changing. And while cancer care may be only number 2 in healthcare costs today, it will continue to grow as the age distribution of the population changes. And so these are great doctors and great hospitals and even important insurance companies, but we must have policy change in order to change the dynamic of rising costs that we see today.
No, I believe it was the first Trump administration that tried to get at this a little bit, right, by saying, hey, we're going to cut our 340B payments in the outpatient rule. And the next rule comes out this summer. We'll see if they try it again. Eventually, the hospitals sued over it and won. So they're getting recouped all that money that had been cut. Is that something that you and others support still to try and reform the 340B stuff that you're talking about, is having cuts to the...
I would say that that diminishes the financial incentive. So what is happening right now in the Tyler Longview market is the Christa system has now bought 4 hospitals in that market. Texas Oncology has been in that market for 30 years. And now they're saying, we now have cutting edge cancer care in Tyler and Longview. And it's really challenging. So if you decrease the arbitrage opportunity because financial incentives work, that is one effective way, I think, to decrease the financial incentive. But in my opinion, the changes needed are much more fundamental. I think that PBM should never be taking profit on the 340B program. I think that we need to somehow make sure that there is transparency and the program is used with its original intent, which is to spread limited resources off vulnerable patient populations. Because HRSA really has had no teeth in regulation. I remember when I testified about this, there were 22 people employed by HRSA. There's no way to commit to whether a hospital is funding social workers for a community-based cancer clinic or whether they're using those funds to put a marble statue in the entryway or fund executive compensation. And so, without transparency, there's really no way to manage that better. So I do think that there are policies that would be more effective in reining in that program to its original intent. However, I do think a decrease in compensation would reduce the financial incentive and alter the natural consequence that we're seeing today of continued rising prices. Because I think it's foolish to think that if you are selling 40% of your goods at a discount, you're not going to raise prices to maintain a stable profit margin. And that is what we've observed today.
Misha, I want to quickly go back to you because you mentioned that one of the consequences of this is patients are getting slapped with higher bills, probably higher coinsurance or copays that are based on, for example, these shots in the hospital outpatient department that are thousands of dollars. What is it like negotiating with some of these vertically integrated systems? Are you telling them, hey, Billy and Sue are getting charged up the butt because you guys have churned your physician clinic into an HOPD? What is it like kind of talking with someone that you have to work with?
Yeah, so I say the conversations aren't usually happening at that level, I think. And for us and other employers, much of the conversation to date has been with your third-party administrator rather than with the hospital itself. You're seeing now a trend with us and other employers start to try and contract directly with those hospitals. Either way, a major issue has been it is impossible to either exclude a hospital from your network or carve out services from that agreement through your TPA or in negotiations with a hospital. There are currently these things called anti-competitive contracting clauses, so that protect, anti-tiering, anti-steering, all or nothing product clauses. They say, you have to have every single hospital or every single service in the network or the plan that we offer. Kind of one example of this, because it can seem really abstract, we have a maternity program that our members love. It's $40, one $40 copay to have a baby from prenatal to postpartum care. We create the program and we're able to fund it because we work with providers who bid for our kind of membership based on price and based on quality and access and a robust set of standards. A lot of hospitals in our network really screamed about this when we put it out there. They didn't want to compete on price, quality, and access. And they said, we need to be in your network no matter what. You can't, steer patients away from us in a preferred program like this. And you know why? Because we have these contract clauses with your TPA that say we have to be in this network, which seems fundamentally anti-competitive to me.
Yeah, and I feel like those contract provisions have been around for a while. And to your point, it makes it such that you can't say no, right? Because one of the big levers that employers have is saying, you're out, you're too expensive. And you're saying that these provisions still exist. It's the hospital saying, sorry, read the fine print. We still have to be included.
Oh, absolutely. Yes.
Okay. Food for thought. Erin, I do want to ask you, one of the things that really helped me unlock this whole concept years ago was the medical loss ratio side of this. And I'm getting to the health insurance services side. So this is the law that says, hey, a certain percentage of your premium dollars has to go towards medical care, where it's the hospitals, doctors. So that money has to leave your door. And once you understand that an insurance company, by owning the providers, whether it's the surgery center, the physician practice, pharmacy, whatever it is, they get to retain that money. Why? Might as well pay yourself instead of paying somebody that you don't own. Erin, can you explain how that has played out? I do think this is like a really big part of the incentives behind this on the insurance side.
So I think that this is like a larger story of regulatory evasion, right? A rule is put in place to limit the amount of profit capture, the amount of insurer profits that can be spent on administrative costs, on overhead. Turn it on. Is it on now? Just lean closer. All right, thanks. That the amount that insurance companies can spend their premium revenue on executive compensation, profit, and administrative overhead because of this medical loss ratio, which for most market segments is 85% of premium revenue has to be spent on medical care, which includes, claims, pharmacy, those types of actual provision of care, and then only retain 15% of that premium revenue for the rest, the overhead, the profit, and the administration. So, and as Bob put it, explained, and as Jonathan explained earlier, this invites an insurance company who has lots and lots of premium revenue to be able to basically back themselves into compliance with the medical loss ratio simply by determining how much they need to move money within their organization from the insurance side of the ledger to the product side of the medical claim side of the ledger. So if you have an internally integrated physician practice, then you pay them, right? And then you can book it as medical cost. You can pay your own affiliated pharmacy claims, and again, send that money over to them. And you can adjust how much you pay. And what we've seen, some of the research that my colleagues have done has shown that that these insurance companies tend to pay their affiliates more than the independents. Why? Well, it could be that they just purchased the more expensive, physician practices when they were going out into the market, or it could be that they're trying to again shift profit from one side of the entity to another in order to sort of hide that money from things like the medical loss ratio. So I think that there are well-meaning regulations like the MLR. There are also other forms of incentives, regulatory payment policy loopholes, such as the way that Medicare Advantage pays risk-adjusted payments, that create all of these incentives to basically capture more and more of the premium dollar, the profit, the amount that we're spending in healthcare as taxpayers and as individuals, by just moving it around the company. And each part along the way, you get to sort of keep the profit within the larger entity, even though it looks like you're basically you're trying to basically raise your profits and then keep as much of it as possible for the investor, as opposed to providing that in actual medical care in a valuable way. So I think that is one of the games, the regulatory games that we see potentially happening, although it's very difficult to study because these large integrated conglomerates are totally opaque. We have no sort of understanding of the relationships or the money moving between these. It's very difficult for journalists, for researchers to study this flow of funds. And so I think related party transactions, it needs to be another place of increased transparency so that we can understand the extent of this issue.
Yeah, and my colleagues and I have found something similar in intercompany eliminations. Remember that term, study it. You find it in all the publicly traded insurers' filings. That kind of shows you how much they're paying themselves for various things. And to your point about some of these companies maybe paying themselves more, what are the downstream effects of that as well? Because, you know, we had spoken with some doctors in New York, for example, that said, hey, Optum nearby is, they're paying their clinics more, and it feels like we can't really compete. Some have considered retirement, just getting out of the business altogether. Can you talk about the second order effects of not just like raising prices to yourself, but what it does for competition in the area?
Yeah, so I think Senator Warren alluded to this. So when you pay your own related part companies more, then you're also paying the independents less, the rivals. And so in some ways, you might be underpaying their cost of providing that service. We see this happen in clinics and physician practices, but also in pharmacies. And so this is the very dynamic that has led to the closure of a lot of these independent pharmacies across the country, is because the independent pharmacy is being underpaid relative to cost of acquisition of drugs. Because if you overpay your own affiliate, you can kind of capture that revenue, and you underpay the independent, frankly, to drive them out of business. And this is extremely anti-competitive, right? And the idea is you're starving your rival because you occupy a competitive position in multiple points of this, of this multi-sided market. You can starve your rivals in one market and then move money to your own affiliates in another, and basically this results in the loss of independence, both independent practices as well as independent pharmacies. They simply can't compete if they're not part of the larger ecosystem. They either have to exit or they have to sell to the giant.
That brings me, so we're going to open it up to questions here shortly, but I do want to ask Debra one more question. And I love asking doctors this. Let's say Baylor, Scott and White comes knocking at your door, or United, and they back up the Brinks truck, right? And we've talked to doctors about this, right? Where they say, like, some of these companies will offer life-changing money. They don't ever have to work again. So in that instance, one of these large hospital systems or one of the large insurers comes up to you and says, hey, we'll buy out Texas Oncology. What would you do?
It's a great question. So, of course, the fighter in me would say that, of course, Texas Oncology is an independent private practice. We're not going to do it. But what I will tell you that is the stark reality is that most people do. And it's much more complicated than that. I think it's easy to say the Brinks truck pulls up to the C-suite and says, hey, let me make you an offer you can't refuse. But I think the reality of it is when you have a lack of site-neutral payment reform, when you have waning margins in your ability to manage a business, you have difficulty keeping and paying your staff, that it becomes hard to continue to run that business. And you have seen organizations make choices, like in the Texas Gulf Coast, the Kelsey-Seybold Clinic is a great example of that, that is now owned by insurance. I think it's United that owns them, because they are able to, or in the hospital system, they're able to get a disproportionate reimbursement structure. They're able to get a lot of preferred benefits, things like 340B, and so it's a challenge. And so while I would like to say, oh, we're not going to do that because we've said no to a lot of individuals in different markets, the truth is that most practices do end up consolidating and vertically integrating. And you see that if you look at the trends, over the period of the last 20 years, over 40% of private independent cancer practices have integrated with hospital systems or insurance companies. And so this is a trend that continues. I think it's why prioritizing legislation and policies to protect private independent practices is really important. Not only is it important to the quality of care and community communities, but also to healthcare costs, things like HR 4299 to hold providers harmless out of the IRA and site neutral payments. But the administration has to prioritize private practitioners if we want to sustain that as a low cost and high quality site of service.
So you have gotten offers in some locations.
Yes.
Okay.
Yeah. And I
Care
will
to
say,
disclose
you know,
the-
we're from Texas, so we're fiercely independent. But yes, I mean, I think that this is always an offer. Everyone in this room understands the trends in healthcare that we see today. And, you know, for individuals, especially in the C-suite, that tends to be very lucrative. And so it is a trend that will continue. I mean, the private providers are going to be less and less. I mean, I tell the story. My husband is a physician also, and he's been leading a practice president for a pediatric cardiology practice in town. It's now like the number 10 ranked program in the country. It's great, but they just aligned with the hospital system last year. So I would say cardiology and oncology are like number 1 and 2 for that trend, but you see it in dermatology, you see it in radiology. So it's a trend that we observe. And the reason why that trend continues is because financial incentives work. And for private practices, which are a very high value and high quality system of care delivery today in communities, it puts them at threat, and their sustainability continues to be threatened.
I want to invite Jonathan up as well. We're going to start taking some questions. So look for microphones. Thank you.
Thank you so much. This was a wonderful panel and opening remarks. I'm John Barquette with Berkeley Research Group. And my question is, what's the principle for how much we should reduce vertical integration? Should Kaiser Permanente not exist? Should a physician not be able to own an MRI machine? I'm not trying to be provocative. I see it at like the biggest levels, how you can say this is really problematic, but and we've had Kaiser for how long? 50 years, and people love it, and it wasn't an issue for all that time. And you can come up with other examples as well where there are two stakeholders that are adjacent in the value chain that work together, and it works really well for people. So how do you think about that?
Yeah, so, you know, the Kaiser Permanente model, one, that they are structurally different entities, like the Kaiser Permanente Medical Group is different from the Kaiser Health Plan and hospitals. But setting that aside, because they are they're basically exclusively and tightly interwoven, is we have spent 50 plus years trying to replicate Kaisers in the market, and instead we've gotten United.
Should they be disaggregated?
So I think that there is this problem of like, if we don't admit that that's where we've gotten with trying to chase this like unicorn of Kaiser, this model that people have. One, Kaiser doesn't necessarily always perform perfectly in many of these instances competitively and otherwise. But to the extent that even if we accept that like what we were trying to go for was the Kaiserification of the United States healthcare system, and instead we got the United healthcare for all kind of, which is like terrifying. And so I think to your second question, or the thrust of your question is like, well, how much is too much, you know, how much breaking up? And I think the first place to start would be with this idea of the Break Up Big Medicine Act, is that certainly that there is, when you are both the purchaser and the seller of a healthcare product, if you're an insurer and you're a physician practice, or you're a PBM and you're a pharmacy, if you're supposed to negotiate at arm's length with each other on behalf of consumers, you shouldn't be part of the same entity. So at very least, you should break them up along that negotiating dyad, so that there can be some real arm's length negotiation, which is separate from this question of site neutral payment and other policies that might create other incentives. Not necessarily, I mean, maybe you break up the hospitals and the physicians, but that's hard, you know, that may be hard to do, but maybe just don't create this incentive that they get to be, they can use site of service arbitrage to, you know, to harm the individual patient.
Yeah, it's exactly right. Site neutral doesn't tell you, you know, you need to sell off all of your providers. It just removes that financial incentive to continue to acquire them.
Yeah, I think there's a lot of common sense we can introduce here. Sorry. You can, everything you need to know about me, you can learn from my ringtone. First is, listen, when size, right? When you have companies that have a massive amount of power and influence, right? That kind of integration is more suspicious. Two, conflicts of interest. When you have massive conflicts of interest on top of mass size, there is a problem. Three is we're dealing with healthcare here. And the fact of the matter is we all understand there's a problem. Walk down the street and ask anybody if they think the healthcare system is working. Ask any physician if they think the healthcare system is working. If patients and providers are so convinced and understand the reality of the situation, we can't let some utopian model of Kaiser allow us to tolerate the emergence of a United. The fact of the matter is we have too much power concentrated in the hands of too few. We have too many conflicts of interest, and we have too many distorted incentives that have been weaponized through things like evasion of the medical loss ratio. And we have overcompensated for trying to invite efficiency by allowing this system to accumulate. And much of this system has not accumulated organically. Let's also be clear about that. It's accumulated inorganically through acquisition, massive amounts of acquisitions that have resulted in these conglomerations. And I think that is the reality that we're confronting today. It's a duck, not a hippo.
And I'll say, I think you have to be careful because it's complicated. Not all opportunities when you see some vertical integration necessarily raise healthcare costs and cause challenges. Like it's been interesting to me to watch many state policies evolve that are talking about really, I think where PBMs are kind of saying, this is vertical integration, you're calling it vertical integration, but also the relationship between distributors and practices, like Texas Oncology is an independent practice, but we have a competitive strategic alliance with US Oncology, which is owned by McKesson. So we are not owned by McKesson, but this is actually a really important business functionality for us to do things like give clinical trials to the patients we serve. In Austin, Texas, I have 80 trials open at my center, business functionalities, technology support, access to capital to grow, that we wouldn't be able to stay open if we didn't have that, and we cost half of what hospitals do. So I think that as we think about how we make policy to try to have more sustainable healthcare costs, we have to be really careful. And I think in that scenario, I feel like PBM saying that that relationship is the same is kind of like Jeffrey Epstein looking at a picture of a family in front of a sunset and saying, you see, you two were at fault because that person is in a bikini. It's like totally different. And so just like 340B reform is absolutely necessary. And if you reform it with a blunt instrument, you're going to put vulnerable patients at risk. And so I think that, healthcare is a multifaceted gem. It's really complicated. And so I do think that we have to have care as we approach this because of the complexity, and recognize that vulnerable patients are not just something that like goes out in the wash, right? Like we have to make sure that we support vulnerable systems that are in place.
Hi, my name is Michelle Sternthal, formerly of Community Catalyst and Roosevelt Institute. So my question is going to reflect this. I'm wondering if we're solving the wrong problem. Like when I think about my dad as a doctor and his happiest time was being at the VA, which one could say is a consolidated, vertically consolidated entity. We can think about Medicare, or when people talk about single payer, you think about, or even the idea of a public provisioning of pharmaceuticals, like the monopoly is the government in that case here. I also think about, places where my local community clinic is now owned by, or hospital is owned by Johns Hopkins, which means, oh, great, my medical records from Hopkins is now over here, and there's like that's something that's useful. Is the question, is it consolidation itself that is the problem? Or is the problem the financialization and profit, and where profit is aligned there? Because I could imagine when we talk about market power or talk about, risk distribution, in some cases, bigger is better in terms of setting. So
let me just start by saying I'm curious what the other panelists think, but pick one, right? You know, if we want a single payer, it shouldn't be United, for example, right? And so the question is, which path are we going to choose? Are we going to choose one that is focused on a free market and competition? And if so, then we have to preserve competition. We have to preserve, we have to impose protections around conflicts of interest and all of these problematic practices. Or we can pursue as a country something that's more akin to single payer, in which case you have a much more regulated system. That is a healthy debate we should have, but we shouldn't, but we need to pick one side or the other.
And I would agree with that. And you probably, I don't know if you know, but my writing is to focus a lot on financialization. And I think they're actually part of like the same problem, actually, that it's not like a one or the other. Although I think that as long as there's this policy commitment to markets and healthcare, even though they're not functioning well, then we have to be concerned about consolidation as long as there's private profit motive as a possibility shot through the healthcare system. Then I think that is then we have to worry about these incentives, about the way we structure payment, and a lot of this is like this financialization is happening even in our public payer programs, right? Even in the Medicare program, we haven't yet quite seen financialization of the VA, although I think that there is some but I think that you're absolutely right to point out that this is, even if we solved the consolidation problem, we may not solve the financialization problem. So to really keep in mind that the sort of how we pay for care, how we publicly provision, how we support, how we give community providers financial capital to survive, to make sure there's sustainable infrastructure in the healthcare system. All of that is like there's a positive building up that needs to happen, as well as a breaking apart, breaking down, in the sense that if we still want some functioning markets to work. But I think ultimately Jonathan's right. Like if we're going to move in the direction of single payer, then that would be, one way to do it. But I think so long as we still have, rampant profiteering in the healthcare system and privatization, then I think we need to think about the problem of consolidation.
Yeah, and I'd end by saying too, big picture, either system that you have, the reason American healthcare is so expensive is because of the price of that care, largely driven by the market power that exists for a lot of these large entities. So whatever system you are pursuing, you're still going to need to address that fundamental issue.
And I'll say the natural consequence, I think, of some of the policies that have been around for a long time that have driven the vertical integration and consolidation in the healthcare ecosystem will continue to do that. And the natural consequence has been that other policies have been introduced to try to rein in that, herd of elephants. And in trying to do that, there are some unintentional consequences that will diminish things like investments in innovation, access to care for patients we serve. And I feel like as an oncologist, as a doctor in the room, that I feel like I touch this every day, because in my 20 years of practicing cancer care, it's been an amazing time where we have delivered amazing therapies to patients who can live well, survive their cancer, survive with their cancer, and live well. And like that is a threat if we don't rein it in, that additional policies will be implemented that will have altered effects on innovation and access in really meaningful ways to patients.
We've got time for one more question. I think back there has a microphone.
So this is kind of, my name is Stuart Hagan with Blue Cross Blue Shield Association. And my question is related to, I think the first question, which is about, is some vertical integration good, I guess was part of it. But I do wonder if vertical integration, if we solve the vertical integration problem, does that actually fix anything if we still have this horizontal consolidation problem? And if we were to take away the horizontal consolidation problem, would we care about vertical integration?
The answer is we should care about both, right? The problem is it's been sort of this arms race, which is we need, provider and hospital consolidation in order to combat power of insurance companies, and then the insurance companies need to consolidate and vertically integrate in order to combat the power of the providers as they get bigger and more powerful. And then we've seen this sort of escalation that has occurred over the course of the last 25 years, if not really 30 or 40 years. And I think that is part of the challenge here is where should power reside in the system? Do we want a system that is competitive and deconcentrated, or do we want one that's concentrated? But if we just pick one side or the other, it's a problem. So I agree that dealing with platformization or vertical integration without dealing with horizontal competition would be missing the plot. At the same time, one leads to the other. And I think that's how we sort of got here with these, sort of multi-tiered, multifaceted sort of gemstone-like markets. And so that's the reality of where we are today and, what's going to be our policy in dealing with it.
I'm going to sneak in one more quick question, Kevin. And this is for Jonathan, just because a lot of this does seem to focus around physicians. Physicians are kind of the referral centers. So much depends on what they say and do. And so just real quick, I mean, so many of these transactions occur below the thresholds for antitrust, right? They just kind of fall below the radar. Would more resources for federal agencies help with that? Or would there still be so many small transactions that occur underneath, the radar that it wouldn't make a difference anyway?
So this is part of the problem with the system as it's constructed. But let me say this. I think if we look at each individual transaction as a one-off in a vacuum, we're going to miss, and we have missed, frankly, as a society, what's happening in terms of the accumulation of power. The fact of the matter is companies don't pursue transactions as one-off strategies. They pursue them as part of a broader corporate strategy to consolidate markets. And so I think one of the things that we tried to address when we revised the merger guidelines in 2023 was to explain that we're going to look at the pattern of acquisitions and we're going to consider the larger march on consolidation that occurs in the aggregate over lots of different transactions. I do think there are things we can do legislatively or policy-wise to make that more effective in terms of resources, but I think the system where every individual transaction is viewed in a vacuum on its own merits, independent of everything else that's happening around it, has not worked and has forced us to miss the plot, which is that there's a much bigger accumulation of power that is taking place across, in many instances, thousands of deals that have a greater effect on concentration in the market in the aggregate than they do individually.
Great. I'm going to hand this back over to Kevin, but Misha, Debra, Erin, Jonathan, thank you. Come say hi to us after as well.
Thank you so much. Thank you, Bob. Thanks for everybody being here. We really appreciate it. I hope you've learned as much as I have. We'll be posting the website of the video of the event on a website after the event. And before we wrap up, I also want to invite you to join us on June 2nd for our next event. It's sponsored by the Peterson Center on Healthcare. Is ERISA up for the job? Improving employer-sponsored health insurance affordability. Hopefully you'll join us for that meeting in a couple of weeks. Okay, take care. Thank you. Thanks.